Welcome back to another episode of Stories and Conversations. And this month, we are talking about a topic that I'm really, really passionate about: healthcare. And the guests that I will have on the show will definitely talk about this topic and some of the things they are doing this year. And today, I have a guest. It's actually a return guest. Yes, a return guest. And I'm sure he's glad to be back. He will tell us whether he's glad to be back and whether the other episode really did something for him and for, the industry. How do I put it? Like the industry that he's in. So he'll tell us more about it, but I'm glad that he's back, and we are going to talk about something that he's doing, something innovative, something that will change the healthcare industry for the better. So before I share so much, I will allow him to reintroduce himself. And if there's anything that he did not share in the last episode, anything about himself, personal or professional, whichever he prefers, he will definitely share that. So Peter, welcome back.
Thank you.
Glad to have you back.
Thank you.
Yeah, so tell us, what didn't you share last time that you'd like to tell us?
My name is Kanda Peter.
Yeah.
It has not changed. Same.
Yeah.
I still work at Ghetto Children's Hospital. And I still chair the Digital Health Committee and Kenya Healthcare Federation. Nothing has changed much.
Yeah.
Still 2 kids. Still the same wife. So we thank God.
Yeah.
Everything is fine. But here for you, I think things are those that have changed. I see Nikuomoka.
I wish.
The
Yeah.
padded seats. Nice. Yeah. So I think it's progress for stories and conversations.
Yeah. We finally made it, if I can say
Yeah,
that.
and I'm happy to be back. The
Yes.
conversations were very interesting last time. I thoroughly enjoyed it. In fact, I think I watched it either 1 or 2 times afterwards.
Oh.
And I realized, did I even say those things? And you realize that there are things, usually you keep reading through the industry that usually stick with you, and you don't even know it, that you've been saying it over a period of time, that it has become like part of the norm for you. So it was nice listening to that, missing those things. I'm like, okay, this is actually important.
Yeah. Are you just being modest, or you were just going back to check if we got your good side? If you were shining, your face was shining.
I was listening to audio in a picture, so I was just listening to audio as I was driving, and then
Awesome. No, but it's good to hear that you actually went back to hear what you shared, and it actually made an impact, because the people who actually shared it, especially on LinkedIn, and the different comments that we were getting on the episode, that was really, really amazing. So you're doing something great.
I would say you're doing at least you're getting us out there, you're creating awareness.
Yeah.
Because sometimes the healthcare industry can't be forgotten in terms of the larger scale in terms of the bigger industries, the finance.
Yeah.
Sometimes the healthcare is left at the back burner. So
That's true.
guys who help drive conversation, get us into the space, really, really helps us to get the agenda going.
Yeah.
Yeah.
That's really great. So what have you been up to since the last time we saw you? Please say something really interesting. Not
When was our last one, by the way?
That was it November or December?
That was last year.
Yeah.
Wow. Okay.
So it's almost a year.
It's almost a year.
Yeah.
Things have moved. Things have moved. So I think I'll start from the KHF side. So in terms of the KHF side, we normally have the Digital Health Committee that sits under Kenya Healthcare Federation.
Yeah.
So towards the end of last year, we were aligning ourselves a lot towards a key thematic area in KHF, which is touching around interoperability in the healthcare space. And that became our key target for this year. How do we get more members within the Healthcare Federation and the larger key stakeholders under healthcare to be able to move towards interoperability? That's under KHF. But also towards the ministry side, the Ministry of Health, there were significant changes that were made on the divisions of the head of divisions under MOH, under different areas. This is under digital health, health informatics, and policy and research. And the guys who came, I'm happy they are my generation. I know them from different circles.
Yeah.
And I think that is a huge advantage, just having I will not say about other generations, but my generation
Yeah.
means we can be able to relate, we can be able to move this thing towards a common goal.
Yeah.
So that was very significant from the government in terms of the appointments
Yeah.
that they made. Then MOH has made significant strides over the last few months, more than I can say. They're really driving towards digital health in a nice way.
Yeah.
That will allow us to do to have shared health records, which is the main goal. Yeah, but that's it's really cool to see what MOH is doing.
That's really great. And you're actually saying something really significant, your generation. And I remember mentioning this in a post just the other day, saying that there's actually a lot of change that has happened within the last year. And how long have you been in this position? Is it a year?
It's a year now, yes.
Yeah, and you've made quite, some changes or some strides towards change, which is really amazing because we know the healthcare industry is so fragmented. And by the time you get to the place that you want to get and make those changes, it takes a bit of time. So this is big. And I hope you can see that it's big. It is.
It is big in terms of the impact on the patient.
Yeah.
Because it drives towards good patient care or patient safety, because a doctor who has all the information about you will be able to give you better care in terms of continuity of care.
Yeah.
I hold the view that health data should be made accessible so that the patient gets better treatment, as opposed to all of us operating in different silos. So creating platforms that will allow this to happen is now our headache.
Yeah.
And that headache starts with standardization. Just agreeing on certain standards, and then now we build it upwards. At the top, you're basically touching on policy, because you've gathered this data over a period of time, you know how people behave. So in the overall end, the person who actually gets to benefit the most is the patient. They get good clinical care at a reduced cost, which sometimes we don't talk about.
Exactly.
Because digital health also drives towards a reduced cost.
Yeah.
You do better financing models, which means that you're able to drive better insurance policies for the patient, restructure how we do our NHIF for the patient. So the person benefiting the most with the most impact is actually the patient.
Yeah. And that's the most important person or the most important stakeholder in this ecosystem.
In the whole ecosystem,
Exactly.
it's down to the patient.
Yeah. So, Peter, there's something that you want to do by the end of this year. So maybe take us through it and be as simple as possible so that we get it.
Okay. So one, we cannot climb the tree from the top. We have to climb from the bottom. The main goal is whatever I just said, shared health records, MOH being able to do policy. And remember that in all this, the custodian is the Ministry of Health. They are the custodians. And they're the ones whom we will give our data, and they'll become the custodians. They'll give us the policies, how we can be able to operate. And thankfully, the Ministry of Health has engaged stakeholders to be able to see how we can align. So through KHF, we've been involved in the discussions around developing the digital health superhighway. So Ministry of Health sat down with different stakeholders, including KHF. We gave our input. This was prepared into a very nice diagram, which all of us we agree with. This was table launched by the president in July of this year. Then immediately it was launched by the president. Now the key item there is now, okay, we have what we need to do. Where do we start? We need to start somewhere. So you start by looking at what are the low-hanging fruits. Low-hanging fruits meaning that what is there that has a high impact and has a low level of effort. Agreeing on standards. So agreeing on standards has the highest level of impact first, and has a high level of impact and is a low-hanging fruit. Requires less effort.
Yeah.
So we had to agree on it.
And this agreeing of standards or agreement of standards, you're doing it with who? Is it hospitals? Is it MOH and KHF. Who are you agreeing the
It's
standards
first
with?
we first sit down with MOH.
Okay.
We get to see, okay, there are many standards out there in this world, that are set out in the world. So which are the ones that we want to align ourselves to? And then now we do a proposition to government, to other stakeholders. We have a discussion around it, and then now we develop a document around the same. There was a huge workshop done by MOH in Syokimau, where Mlolongo, where we sat down, we went through this, we did different proposals for, this is what we'd like to adopt at this time. We also asked the ministry to help us by giving us direction. Uh, uh, this is the standard we've agreed on. What are the dates for us to be able to comply, so that we all move together towards that goal? So the easiest one in terms of this is ICD-10 coding. I think it's good to be specific about standards, because I think they're also quality standards. We're talking about technology coding, basically. So the first one was ICD-10, ICD-11 coding. So we've agreed we move to ICD-11 coding. It's been there. We just need to transition, all of us, because there are some guys who are caught up in ICD-10, ICD-11. There's a cost component to it. Ministry of Health has taken it away by developing a terminology service called the National Health Data Dictionary. Through the National Health Data Dictionary, we can all have one single point of reference, where we, as the stakeholders within the healthcare space, can refer to this terminology service called NHDD and say, refer ICD-11 as per the terminology service there. The other one is also something called procedure codes, which is LOINC. So basically, when a doctor does a request for let's say a lab test, we need to standardize that. So we are going to standardize that. We've done a proposal for LOINC codes, and now we are setting a cutoff date to migrate by December of this year. So all stakeholders within the Kenya Healthcare Federation, we want to move by December 31st. All of us are using these standards, at least for beginning, ICD-11 and LOINC codes. And then what that means is now we are able to report better to MOH. They're able to know the kind of diseases that are out there. And then for the other side, in terms of the commercial side, raising of things like claims, they're standardized. There's little rejection when it goes to insurance companies.
Okay. So all this standardization is on the hospital side. That's what I'm hearing you say. Or is it on the hospital side and the insurance side and all the stakeholders that are involved in the patient journey?
So it's important to say that AKI, Association of Kenya Insurance, has not been left behind. They have also been involved in the same discussions with the Ministry of Health. They participated in the same forums. And they were also in the space of looking at how to drive interoperability and how to be able to standardize the sharing of data within the healthcare space. But since MOH has provided guidance in terms of us, how we're going to do it, Association of Kenya Insurance, Kenya Healthcare Federation, other key stakeholders will all align to what Ministry of Health has set aside and refer to their services, like the terminology services, for as a point of reference. So we are all aligning towards one standard, so nobody's essentially left behind.
That's really cool. And I mean, when you talk about Ministry of Health, people feel like Ministry of Health, people think Ministry of Health is very rigid. So I mean, you sharing that, I mean, they've come together and they've decided to bring this thing forward and obviously make it happen. That's really amazing to hear, and I know it will make such a big difference. So I'm sure as you're doing all this, you've experienced a couple of challenges. So are you getting a lot of, or rather some few barriers from people, from stakeholders, from hospitals? Are you experiencing that challenge, and how are you dealing with it? And how can people feel, or these stakeholders, how can they feel like this is actually very important and it will make a difference, not only for the patients, but also for efficiency of, providing services in the hospitals?
Okay. So I'll try to, I don't know whether I should play politics, but Politics aside,
Yeah.
man, the conversation about us moving to one standard has been there for a very long time. It's a tiring discussion.
Yeah.
We should just move. I don't know why we keep having this discussion. Was it guidance? Okay, MOH has given us guidance. Was it a point of reference? Ministry of Health has given us a point of reference. I tell you, the amount of effort that has been put by the Ministry of Health over the last 6 to 7 months is crazy. And the kind of tools that have been put there. I've not even talked about unique patient identification because the service is already out there. They're going to set up the Kenya Health Workers Registry. You can be able to confirm the doctor, the practice. The discussion further goes down to how can we confirm the drugs that have been approved by PPB. The discussions are really advanced, and the actions that are there in terms of outputs is that you can go right now to your browser, search for National Health Data Dictionary, and it will be there, and you can use it as a point of reference. So I can say that there's a lot of work that has already been put by the ministry. For us, in terms of the healthcare space, when we looked at it with the integrators, and this is Smart, this is Slade, this is MTBA, LCT, and you look at it from the technology space, moving to a standard we both agree works perfectly for them, because it takes away a lot of headache in terms of managing of code updates, all those things. It takes away a lot of headache for them. The biggest challenge we have is actually training users. We have such a short time where we need to train all the doctors, move all the doctors, all the nurses to know about ICD-11, and that's the biggest issue right now in terms of movement. I suspect there will be one or two challenges, especially at the ICT leadership in particular organization, because there might be a cost component in terms of configuring systems
Yeah.
to move. And that is, for me, if you ask me, if you look at the number of rejections you get in a claim, it's a better off investment just getting into doing that standardization.
Yeah.
Yes.
Yeah. But let me ask, and this is, I don't know if it's from a layman's perspective, ICD-10 and ICD-11, I mean, it's disease coding. So it's not a big difference, right? Malaria is malaria.
Not really. They're like, you might find like 3 or 4 different types of how malaria is
Yeah.
coded.
Okay.
And it's important because you go to a particular place, the kind of malaria they get might be different from another place. I'm not a medic, but the good thing is this: when you have proper coding for those conditions, for that disease, 5 years down the line, you'll have good, accurate data that will drive research and policy. So you can be able to say, based on this, these are probably the factors that are causing this. Let's implement this policy.
Yeah.
So it's best to look at it from that angle. Yeah.
Okay.
As opposed to generalizing. The more accurate we are, the better.
Yeah.
ICD-11 brings, I think, 15,000 more codes apart from aside from ICD-11.
Yeah.
Which means you're able to code vaccines, more procedures, all those things. Yes.
Yeah. Yeah, I mean, I'm saying that because I can remember when I was working for one of the organizations, that ICD-10 coding stuff, like it was such
Was
a
a big thing.
painful it was such a painful process, especially for the insurance companies. I think the hospitals were a bit more flexible, but for the insurance companies it was something else, because most systems are not integrated. So pushing that data and all that, it was, oh my gosh, that was so painful. So I can only imagine what will happen during this period. And you believe it will happen?
It will happen.
Yeah.
It will happen.
Yeah.
This is in terms of I know for our members, we have the motivation and we have the commitment to do it.
Yeah.
then from that it can become a point of reference and case studies for government also,
Yeah.
to as others are doing their transition. Yeah, but for sure, in terms of commitment, it's there. We're going to
Yeah.
do it.
Yeah. And this is on the road to data sharing.
Yes.
So what timeline are you giving for that?
For data sharing,
Yeah.
ah, I think you're hosting a government official very soon. I
Yeah.
think I'll leave that one for the government guy to answer.
Oh my gosh, yeah.
Because
Yeah.
I can't comment much on it, because the infrastructure they set up in terms for sharing health records
It's
sits with
there.
him.
Oh,
Sits with
it's
them.
with MOH.
It sits with them.
Okay.
They will give us the tools to be able to uniquely identify a patient,
Yeah.
which is good because you end up reducing fraud and all these things that is happening within the healthcare sector. And we could be able to know better about our populations in terms of how we are doing health wise. Um, and then we also did a request for the minimal data government requires us to share. So we are waiting for that communication as well.
Yeah.
Yeah, so that we
Okay.
know. Yeah.
Okay. So I don't know if this has ever been done before.
Okay, ask away.
Has it been done before in any other country, or is this a first in Africa or in the world?
In the world, no. In the world, for sure. In the world, is shared health
Yeah.
data. Uh, to what extent, I don't know.
Yeah.
But in Africa, for sure, if we be able to crack it, I will be a pioneer country.
Oh wow.
Yes.
Wow.
I know for sure we'll be a pioneer country in terms of shared health records.
Yeah.
And that means you're basically having a place where any doctor within Kenya can be able to access your health record and give you better treatment.
Wow. Do you think this will happen for real? Like, let's just unajua. There's the
Oh,
practical
kuna
side,
yeah.
and then there's the
The
you know.
utopia.
Yeah, yeah, yeah. As in, practically speaking, hospitals don't like sharing data because that's like, I know it's not a source of income, but it's, you're protecting their information in a sense, right? So do you think it will actually happen,
It will happen.
practically speaking?
It will happen.
Okay.
It will happen. And the reason why it will happen is because, one, we are operating in an environment where we are enabled. We have a Ministry of Health that is enabled to act fast, which is good for us.
Yeah.
Two, in terms of the policy, we have the digital health bill coming up. It will enable some of this. We have platforms. We have the digital health superhighway that is coming up. The digital health superhighway has a good security framework around it, cyber security framework around it, to ensure that your data is safe. The person who gives access to that data is the patient. So you get so that will be defined by the technical working groups that are working around the cybersecurity space. There's also less with MOH has less with Ministry of ICT in terms of provision of some of these services. The way to look at it is this: we stand with standardization. We've agreed on the standards. We agree on the minimal data that you need to share. You can share the patient unique identifier, which is there. Even if that data is sent across, nobody will be able to identify it because it will be using a unique patient identifier from government. Then the other one will be the minimal. The other minimal data will be like the disease coding, maybe that the lab results that were there per that encounter. So be a minimal set of data that you'll be able to share out, and probably the history that the patient gave, and that becomes what is shared out. If I look at it in terms of currently private sector, what data are we collecting? Which one is most difficult? Disease coding, guys are already doing it, so that can be shared out. We agree on the how to do lab in terms of standards. That becomes the next headache for us. History taking is already digitized. Some of this data is already being passed through aggregator services or integrator services like Smart, Slade. So this data is already existing and already has like web services around it. And you just need like one or two good use cases for you to streamline the services with MOH and then now do a rollout. Yeah.
Wow.
And good thing is MOH told us guys, just get us uh, early adopters to test these services. And we got close to 7 or 8 guys who were willing to actually try out and become early adopters for their MVPs.
And this is hospitals, 7 hospitals.
Hospitals,
Yeah.
integrators. Yeah,
Okay.
yeah. They put themselves at the forefront, saying, "Yes, let's go ahead, let's test it out."
Okay. So maybe it's possible.
It is possible.
Yeah. I'm cautiously optimistic. Let me say that. Cautiously optimistic. But I'd love to see it, for sure. I'd love to see it because I know it will make such a big difference. Because I know this conversation has been had for such a long time.
Yes, it has.
Yeah. So anyway, as we come to a close of this conversation, why now? Like why now? We've had this conversation for like eons. So why now? And why you? Why are you doing it?
I think it's not even why me.
Yeah.
I think it's actually more than why not now.
Yeah.
It's actually why not now. We are sitting in a place where technology has become more affordable. We are better connected. You have better access. Before, if you went 10 years earlier, guys were 30% digitized. Probably they were using digitization was really for billing and registration. We are way more than that now. We guys are using other services on top of just collecting data. We've seen people leveraging out AI services to offer patient care. We are now seeing telemedicine services. That means guys have already built on the other existing platforms that they had, and now they're going to the next level. So the opportunity is there. It's there. What was lacking was actually the policy and the frameworks for us to be able to talk to each other.
Okay.
When you go to the banking sector, under the banking sector, they have proper frameworks to talk to each other. And then they've worked a very nice way to operate. They have Kenya Banking Association, KBA. They have Association of FinTech, which meets with Central Bank. So they've known a way of thrashing out their frameworks. For us in healthcare, that is now what is happening.
Exactly.
We have key stakeholders who are now thrashing out frameworks together with the ministry so that we are able to create a pipeline or create an environment where we can actually share the health records.
Perfect. So it sounds really amazing. So as I said, I cannot
I've been
wait
accused
to
of
see.
being an optimist, an overly optimist. So I'll continue riding my horse, Pole.
Yeah. I mean, in the healthcare industry, no, I'm part of it, so I know.
Yes.
But I mean, with people like you, and I know Dr. Ran of MOH, things are moving. And also Dr. Theory of the CEO of KHF. So I know things are moving, and I'm glad to see it. I'm glad to be a part of it. So if a stakeholder, someone, whoever wants to be part of this innovation or wants to be part of this, horse that you're riding, what can they do about it, or how can they become a part of it?
Okay. So first, I'm very happy. Most of those guys you've mentioned, okay, no, actually all of them are actually our generation. Dr. Ryan, Dr. Tim, Dr. Job, all our generation. So it's nice to have us driving that agenda. I hope that will be something positive. So how do you join into this into this discussion? One, you're an organization, you're out there, you want to see how you can play. The easiest one is go to KHF, register yourself as a member. For KHF, I almost said the fees are passing down here. Anyway, the KHF provides an avenue to be able to meet with the different stakeholders. So KHF is a good space to be in. I think that's what I would probably recommend for anybody who wants to get into the space. For an individual, same thing. You can be able to work with KHF and contact the offices and see how you can be able to become part of the discussion. And I'm sure I probably will get the guidelines in terms of individual membership. For under KHF.
Yeah. Awesome. This was great. And I mean, all the best. I know you'll do it.
Yeah.
I have all the faith in you.
All the best to you. You're in the same space.
Yeah.
Yes.
No, we're doing this together. So thank you for coming to the show again. I'm sure you'll be coming more often than not.
Yeah.
Yeah. Next time unaweza tuletea some snacks.
I'm saying the way you're continuing like this, I think the next time we'll require passports. But I hope the
Amen.
next time when we come, we'll be
Yeah.
talking about the actual outputs
Exactly.
of what has happened.
Exactly.
I'll be happy to come back
Yeah.
to say how the journey has been in terms of adoption of the standards. So maybe towards the next year we can have discussions around the same.
For sure. For sure. Thank you, Peter. Stories and Conversations with Rahel is all about life, career, leadership, and healthcare, a topic I'm very passionate about. Thank you so much for watching. Share, like, comment, and subscribe for more.